here, so we'll go on to the second talk of the session, and that is visual and refractive results with Visumax 800. First 1000 eyes. We all know Dr. Sri Ganesh loves technology, motorbikes and motorcycles.
But, and my friends. And my friends.
And my friends. Okay, great. But I think he is really a gifted surgeon and really knows how to get the best out of technology.
Don't start the timer.
Which we could see yesterday, and I think he was also involved with the trials for the development of the Visumax 800. So who else than Dr. Sri Ganesh to talk about visual and refractive results of Visumax 800.
Thank you, Dr. Maipal. Good morning, dear friends, and I would like to present our results of the first 1000 eyes with the Visumax 800. We were part of the global trials for the 800, and I am a consultant to Carl Zeiss and Biotech. So if you look at the workflow of the Visumax 800 and how it is different from the 500, you have a laser arm that descends, you select the treatment, and then here that is attaching the PI, and here instead of the bed moving up like the 500, the laser arm moves. It also has a top and side camera view so that you can actually adjust the PI onto the patient's cornea by looking at the cameras. And then this is the infrared to have the centration guide. So this Visumax 800 has a centration guide where you can center on the visual axis, and that is how it's different from the 500. You can see that it shows you if you're away from the visual axis, that's a cord which you have to shorten, and then you can dock on the visual axis. It also has cyclotorsion adjustment, but you have to mark the 180 degrees, and then by rotating the joystick, you can actually rotate the axis of placement of the treatment, and so you can compensate for static cyclotorsion. And the laser itself is much faster. It is 2 megahertz laser. So the laser in real time takes about 8 seconds for a 6 mm zone and 10 seconds for a 6.5 mm zone. The laser arm goes up and the microscope arm comes down. It's robotic arms which are, and you can see that is the dissection. The laser pattern itself is very nice without OBL, and then you have a smooth dissection. So the treatment time is greatly reduced. Coming to the results, total number of eyes operated 1036, 2 weeks follow-up available for 870 eyes. We used a nomogram, same as the 500, 10% overcorrection for sphere, 15% overcorrection for cylinders with the rule, 10% overcorrection for oblique cylinders, and for against the rule astigmatism, no correction. Our average age of patients was 27.4. The spherical equivalent treated was minus 4.21, and cylinder was about 1 diopter. The corrected distance visual acuity pre-op was minus 0.08 logmar, and we used an average optical zone of 6.3. We also did the HD analyzer, and the pre-op average OSI was 0.65. And if you look at the post-op outcomes at 2 weeks, you can see that between the first day and then 15 days, the uncorrected distance visual acuity didn't change much. It was excellent, 0.03, minus 0.03, that is better than 6.6 on day 1, maintained at 15 days. Residual sphere on day 1 was 0.0016, so excellent correction, almost plano. Residual cylinder minus 0.019, spherical equivalent minus 0.0082, and corrected distance visual acuity minus 0.37, which is similar to the pre-op, but at 15 days minus 0.1, which is actually better. The OSI on day 1, you see from pre-op 0.65, it increased to 1.52, but still acceptable. Anything below 1.5 is good, and at 15 days it was 0.96. This is the 15-day post-op results. 99% of the eyes were better than 20/20. You can see that, and 100% of the eyes better than 20/25. So the efficacy index was excellent, 1.23. And if you look at the safety index, it is 1.08. If it's more than 1, it's very good. So 84%, no change, 11% gained 1 line, and 5% lost 1 line. There were no eyes that lost more than 2 lines of best corrected visual acuity. This is the spherical equivalent attempted versus achieved, and you can see that the scatter is very good, quite tight around the central line. And this is the post-op spherical equivalent. 99% were within half a diopter, so very good refractive accuracy, and 100% within 1 diopter. And this is the refractive astigmatism. Again, correction is better because of the cyclotorsion compensation and the nomograms used. 98% less than 0.5 diopters and 100% within 1 diopter of cylinder. You can see that 92% within a quarter of diopter of cylinder. And this is the stability over time, but this is only 15 days, so it's not very significant. If you look at the OSI also, pre-op was 0.65, it reduced to 1.52 on day 1, and again 15-day post-op it was 0.96. So the quality of vision, it shows the scatter. If the scatter increases, then the quality of vision is less. If it's more than 1.5, then it affects the quality of vision of the patient. But you can see here that even on day 1, it's fairly acceptable. This is some of the examples of the HD analyzer with the OSI. Pre-op OSI 0.5, post-op day 1, hardly any change, 0.6. You can see that the MTF is quite good, and 15 days, it's actually better than the pre-op, 0.2. This is another patient pre-op, 0.4. You can see the point spread function. First day, 1.4, it is worsened, but 15 days, it's again 1.1. So the scatter actually is not that much. So to conclude, the Visumax 800 is the latest femtosecond laser to perform SMILE for myopia, and hyperopia will be shortly available. We conducted the global trials for hyperopia also. Lenticular extraction technique is the same as the Visumax 500, which is an established technique with proven clinical results. Now, if you ask me whether there's a difference between the 500 and 800 in terms of refractive and visual results, we did a comparative, randomized comparative study, one eye 500, one eye 800, and we did not find any difference in terms of visual and refractive results between the 500 and 800. But the only advantages of the 800 is that it is faster. It just takes 8 seconds compared to 25 seconds of the 500, and it's got surgeon supporting functions for centration and alignment. So it's never been easier to start with SMILE. It's much easier for the beginners. And the 2-week post-op results demonstrate excellent correction, visual outcomes in terms of efficacy, and significant improvement in uncorrected distance visual acuity, corrected distance visual acuity, and the OSI. So the quality of vision also is very good. Thank you very much for your attention.
Any questions for Dr. Sri Ganesh? So Shri, basically from the perspective of this particular machine, the marking is still required for cyclotorsion.
Yeah, 0 180 degree marking you have to do, but then I think shortly in the next software upgrade, it will take the image from the IOL Master 700, so you have an automated cyclotorsion and a markerless system.
Did you really find a significant difference between marking for astigmatism and not marking? Between
yes, that was a study which we published in the JRS, and all cylinders, whether it's a toric IOL or whether it is LASIK or with SMILE, have to be on axis. If your cylindrical correction is not on axis, for 10% of rotation of the cylinder, you lose 30% of your correction. And at 30 degrees, you lose all the correction, and it becomes worse if it's more than 30 degrees. That's a known fact. It's undisputable. So why would you not want to place the cylinder on axis? Even spectacle glasses, if you rotate your glasses, your vision is terrible. So you can have loss of best corrected vision, you can have poor quality of vision if your cylinder is not on axis. So we actually defined, I also have a SMILE marker which is available from Epsilon to mark the cornea and then compensate. So we described this technique of rotating the cone on the 500, but with the 800 you can use the joystick, and then shortly you will have automated rotation. See, it is significant in about 8% of patients. So if you look at the overall, there's a globalization, you may think it's not that much difference, but if you look at one individual patient who has like a 12-degree rotation and a high cylinder, like a 3-cylinder, yes, that patient is going to be very unhappy. But when you look at the whole statistics, thousands of eyes and then 8% with significant cyclotorsion, it may not make that much of difference. But for that individual patient, yes, it will make a difference.
So there were approximately, I would say, 3 major criticisms for the SMILE procedure, specifically in the FDA trial, because that the energy utilization, etc., was not optimal, etc. So the first thing was slow recovery of vision. So I just from the point of view of audience, I am just asking, so how many of your patients achieve 20/20 or 6/6 vision the next day?
You see, it's 99% almost which have.
Okay,
so
and is there any difference between 500 and 800 as regards vision?
We did a randomized comparative study, one eye 800, one eye 500, and we found that in terms of visual outcomes and refractive outcomes, there was no difference, because even with the 500, we did the cyclotorsion compensation and the centration depending upon the visual axis on the atlas. So we found that there was no difference between the 500. The only thing that the 800 is more sophisticated, it's faster, and it's got surgeon supporting features, so you don't have to manually adjust it. But otherwise, as far as, yes, the difference is about 15 seconds.
So basically, the first criticism, I kind of second what he's saying, is the first criticism being about visual recovery being slow is no longer valid. It was there in FDA because the energy that was being used was much higher than the optimum that was to be used. The second was obviously the cyclotorsion compensation, which possibly led to suboptimal results in astigmatism. So
and they didn't have any nomograms. They didn't use any nomograms. They didn't have energy optimization. The optical zones were fixed. The spot spacing and was different from what is being used universally. It was much smaller, and so all these things led to poorer results than what we get internationally.
And the third thing which was there was essentially regarding the surgical proficiency required to remove the lenticule. So do you feel it's still difficult for people to adjust to getting the lenticule removed?
I think surgical technique, it is a surgical procedure. It is, the learning curve is a little more than LASIK and definitely more than PRK. So you need some amount of surgical finesse. So if you are meddling in the interface for a long time, you will have more inflammation and edema, and visual recovery will be delayed. So surgical finesse and technique definitely contribute to early visual recovery.
Thank you, Shri.
Thank you.